But I specifically now want to look at the Northern Territory and Aboriginal health and what are the key social determinants of health. The first one, as I said, is access to primary health care. And that explains this graph. If you go back to 2000, which is when the improvement started, Alice Springs Hospital is worth $50 million, and the average per capita primary healthcare expenditure in Central Australia was around $600 per person, with the worst funded health services at $330 per person and the best funded at $1,500 per person. And there was no, whether you got money or whether you didn't depend on need or any sort of rational planning process. It just depended on what electorate you're in and whether you got political mileage out of the former Country Liberal Party at that time. Labor came to power and they did some very significant things. The hospital system within a few years, Alice Springs Hospital had gone up to $150 million, trebled its budget, and Royal Darwin went up a hell of a lot. Alice Springs Hospital in 2000 had one unit that was accredited, that was the paediatrics unit with an Australian trained head, and no registrars anywhere else except in paediatrics. And within a short space of time, every unit was accredited, every unit had registrars. They introduced mortality review, quality improvement system. So the quality of what was happening in the hospital system across the Northern Territory went through the roof. But at the same time, primary healthcare funding through the Primary Healthcare Access Program expanded enormously as well. So we now have gone from an average of $600 per person to an average of about $2,500 per person in primary healthcare expenditure, with core services, core indicators and a whole range of other things that have dramatically improved the whole health system. And I think this is an important story about the impact that a health system can have on health, but within the limits of the fact that that projection that they make in this report, this is the COAG Indigenous Reform Council report, I don't think that's going to continue, because the gains that we can make from the health system we've made, we're not going to make a lot more gains by just improving the health system. If we're going to keep that going, we've got to do something about early childhood and educational attainment. And that's the challenge ahead of us. The story about how the health system improved, I think, is an important one, because back in the days of ATSIC had $52 million for Aboriginal health. And in that era, ATSIC felt that health equaled infrastructure. So they were putting health money into roads, into buying cattle stations, into the old public health type things, but they thought health services didn't matter. And the head of ATSIC actually thought the same thing, that health services didn't matter. They misunderstood the literature. They used to quote Thomas McCowan and said that he'd said that health services don't matter. So if Aboriginal health's going to improve, we've got to buy cattle properties, we've got to create employment, we've got to build roads, we've got to have sewage, water, all that, but we don't need health services. And ATSIC was a brilliant strategy by government at the time for getting Aboriginal organisations to fight with each other. So if you wanted to get money for your health service, you had to go into battle through a regional council process with the land councils, with the housing associations, with the legal service. We all got funded from the one bucket. There was nowhere near enough money in that bucket, and in that era we went from a period where we used to work together to a period where we were all fighting with each other for inadequate money. So Congress and the Australian National University produced this document called Beyond the Maze, and we analysed that situation, and we basically recommended that there's lots of problems, but the most important was there was inadequate funding in ATSIC, that ATSIC completely undermined the role of community control health services, and it did that basically by an attack by using the language of self-determination. People said, well, ATSIC's run by Aboriginal people. Why would you want anything other than ATSIC to fund you? That's self-determination in itself. Whereas Aboriginal Health Service was saying, these services were set up by the community. They actually reflect self-determination at a community and a family level. ATSIC was a government-imposed structure. So also there was inadequate expenditure and there was no data on what was happening. So AMSAT was set up in 1994 for the purpose of an alliance to advocate for the transfer of health funding from ATSIC back to the health department. That's why AMSAT got going. It's now much more than that, but that's originally why it was set up. And it lobbied for, along with Noel Pearson and some of the land councils, AMSAT led a delegation to Canberra and lobbied the then Labor government to transfer health from ATSIC to the Commonwealth Health Department. And in doing that, there was a whole heap of agendas. One was the Health Minister is a senior minister on Cabinet, has power. The Aboriginal Affairs Minister was junior. The Health Department's got all the money. That's where MBS and PBS is. We were completely locked out of that. We used to rely on grant funding from ATSIC, and we were completely locked out of mainstream money. And at that time, when the research was done by John Deeble, the average Medicare expenditure was 27 cents in the dollar for Aboriginal people, and PBS was 21 cents in the dollar. So Aboriginal people were seriously missing out on the mainstream dollars which were in the Commonwealth Health Department. And also, the ATSIC bureaucracy was not health literate. They didn't understand health services. They didn't think health services mattered. Whereas at least in Commonwealth Health, there's a bureaucracy that actually understands people have to have access to healthcare as well as other issues. So for a whole range of reasons, that's what we argued for. That's what happened. We ended up with framework agreements. We ended up with joint planning structures throughout Australia. We ended up with a lot more money. July 1, 2006, we got access to MBS, bulk billing doctors in Aboriginal health. And then in 2008, we got access to Section 100. Now, just for Congress, where I work, Congress now generates around $3 million a year from Medicare. And last year, the PBS for our pharmacy was worth $2.2 million. Now, before that, if you go back to prior to this era, we used to have to pay for our own drugs out of our grant money. So we used to have red spot drugs in the pharmacy, things like statins, and they were the expensive ones. And if you gave out too many of them, you're in trouble. You'd blow your budget. So getting access to an uncapped system like this, which people now take for granted in the Northern Territory, was a hell of a struggle. And it didn't just happen overnight, and it took a lot of advocacy from the Aboriginal Health Services, which is what AMSTANT led.